Good evening, everyone. Welcome to FACT Foundation webinar. On the left main interventions. We have stalwarts of in both from India and abroad, and I have my good friend as circulated before. We would have by Dr. Ajay Kirtane, and we will have calcified lesions in left main multivessel by Dr. Samuel Matthews. Then we will have imaging by left main by OCT by Dr. Giulio from Italy. Then we'll have experience sharing how to improve outcomes by Dr. Praveen Chandra. And then in the end, we'll have New York, Columbia experience sharing of COVID cases. Then finally, we will have a discussion and question and answer session in the end. Over to you, Dr. Sushil, for a few words, and then we'll go on to the presentations.
Thank you, Srinivas, and thank you for organizing this. I think this is a great way in this little time to sort of meet and share and discuss the issues that we used to do in person. I think it's obviously that you have experts from everywhere here to discuss the issues, and we're going to focus mostly on the topics of our daily practice: left main, OCT, coronary intervention. But I think in this time of COVID, and as many of you know, in New York, we saw a very great surge of COVID cases. We saw this disease process presents like no other, and there's a lot of different manifestations. And Dr. Amir Masoumi from our institution has been sort of looking at that very closely. And I think, the pandemic goes up and down across different times, and I think this may be useful information for others. And in Italy, we learned lot from our Italian colleagues, and hopefully to try and manage through it, this is very helpful. Again, it's a pleasure to be here, and look forward to the talks and a great and lively discussion.
Yeah, I think now we'll go on to the presentations. The first talk will be Dr. Ajay Kirtane. As all of you are aware, he's the Chief Academic Officer, Director, Interventions, Cardiology, Columbia University Medical Center, New York. His work as of late has become increased with these COVID times, where each procedure he needs to approve, and then that's how the procedures are planned in these tough times. But in spite of these tough times, because of a relationship and various other reasons, many of the Indian colleagues were wanting to hear from you, Dr. Ajay. Thanks for giving us the time. And then probably 2020 is an important, is bad one way because of COVID, but we have got a lot of new data on left main interventions. I think we need to be having listened to you regarding the 5-year Excel and the long-term data of 10-year follow-up, which we come across, which we now have. I think with this, over to you, Dr. Ajay, for your presentation.
Thanks so much for having me. It's all our colleagues over there. It's just, it's great to be able to participate in these types of endeavors, just as Sushil said. And for us, thanks for allowing us to do it on a Saturday morning for here. So hopefully we can get through and learn a lot of things, and then you can hopefully still enjoy a little bit of the evening for you in India. So I wanted to talk a little bit about left main disease. And as Srinivas said, there is a fair amount of data, but there's also a lot of controversy, allegations, and hopefully what we can do through this talk is to talk about how we take care of patients. And what we try to do as clinicians is we want to take care of our patients the best way we can, knowing what we know, but also applying the evidence to those patients so we can make the right individualized decisions. And hopefully that'll come through during the course of this talk. We have several other talks as well, and at the end we'll have time for questions. So I think that's important to answer your questions. These are just financial conflicts. It looks like a very long slide. Bottom line is I don't take any personal money from anybody. My institution gets a lot of funding, and then for travel and meal expenses for meetings, they're listed here. So this is a full disclosure in case anyone was wondering. The first question I think it's important to mention is, do we need to revascularize left main disease? And why are we even asking this question. As interventionalists, we know that we should be revascularizing severe left main disease. The reason it's important is because in light of ischemia and in light of what many are saying about the limited role for cath or revascularization on the basis of that trial, it is important to remember that left main disease was excluded from the ischemia trial in particular, and that's because there's randomized trial data showing that revascularization through surgery is associated with a mortality benefit over medical therapy alone. Now, we don't have randomized PCI versus medical therapy data. Similarly, many people have criticized these older surgical studies for saying that, there was no statins and there was no medical therapy in these trials. But recall, these studies were relatively small studies that showed a true mortality benefit. And because we can generally say that PCI and surgery have similar mortality outcomes, and I'll show you that data a little bit later, that's why we know, or we can say very confidently, that this lesion subset, left main disease, is not one to be trifled with, and patients with legitimate left main disease would benefit from revascularization, not just for symptoms, but in addition for prognosis. Now, then the question comes, okay, so we've diagnosed left main disease, and remember, as an interventionalist, diagnostic the capability for left main disease is not just based upon the angiogram alone, because the angiogram can be misleading. You may have to do adjunctive testing to determine if the left main is significant. But if it is, how should we revascularize it? And that's where the crux of the data for this year comes in. So what I'll cover briefly is Excel, Noble, meta-analyses, controversy, and then hopefully get a synthesis of where the data is. So first, the Noble trial, 1,200 patients allocated to PCI or CABG and followed out for a period of 5 years. It's notable that this is not just cherry-picked osteal left main disease. This is kind of everything. And as you can see, the left main was stented at the bifurcation in almost 90% of cases. In addition, even though this was sort of not a trial that was run, per se by Abbott or anybody else like that, this IVUS use in this trial was almost 3/4 of patients, and you'll see the same for Excel. So the bottom line is, if you want to apply this trial data to your clinical practice, you need to use imaging in these types of cases, and we'll talk a little bit about how to do that at the end. Here are the primary results out to 5 years. This was presented at TCT earlier this year and published in the Lancet. And what one can appreciate is the composite endpoint of MACE was increased with PCI relative to CABG. Now, if you break this down into what are thought to be the harder endpoints of death, MI, or stroke, this also favored CABG, although not statistically significantly so. But just examining the curves at 3 years, you can appreciate that there's sort of early evenness and then late separation, and this is going to be a common theme. These are, again, the 5-year data for MACE showing benefit in terms of CABG over PCI. And here is sort of all the composite endpoints together so you can figure out what's actually going on. And what one can see is there's no difference in all-cause mortality to 5 years. There is an increase in revascularization seen with PCI relative to CABG. Stroke favors PCI, and non-procedural myocardial infarction, so excluding the procedural events, the late MIs favor bypass surgery. This is going to be very consistent with what we see in the Excel results. Now, this question of procedural myocardial infarction is one that's a very hot question and a lot of confusion about it. And the reality is that in this trial specifically, the investigators did not actually look at procedural MIs. So in many senses, it's more common to clinical practice. Most of you, certainly we, don't routinely check cardiac enzymes after PCI. We only check them if there's, a major event, chest pain or something else like that. And Noble was actually orchestrated that way in addition. And so I think it does reflect routine clinical practice in many ways. Now, it's also important to recognize in terms of secondary endpoints what happened. And it's not just the target lesion that has more repeat revascularization with PCI, it's also de novo lesion revascularization, which suggests that because you're treating somewhat focally with PCI, there may be other lesions that are being missed that are not successfully treated with the initial endeavor. It's not clear to me whether that's because of protective effects of bypass grafts or the fact that we tend to do a more limited revascularization. I think that's an open question that needs to be sorted out a little bit further. Moving on to the Excel trial, this is a bigger trial, randomized 1,900 patients to PCI versus CABG. I think many of you are aware what the baseline data was. Again, I'll point out that the bifurcation was treated in approximately 80% of patients within this trial. It's also important to point out that both these trials tried to limit the syntax score eligibility. And the reason for that is that if you have complex left main and multivessel disease, I think most of the prior data and just clinical intuition would suggest that those patients may be more ideally suited for CABG. So equipoise perhaps is lost. So these patients were restricted, at least by trial inclusion criteria, to low and intermediate syntax score. What's interesting is if you look at what the core lab said versus what the site said, there was actually reasonably good representation of higher syntax scores. And I think what this means is that as interventionalists, we often just focus on the tightest lesions and don't actually comprehensively look at the entire angiogram, which is why I always feel that the heart team approach is the best approach. I've been very, very surprised actually in my clinical practice over the years that when we think we're going to do something and then we show the films to a surgeon, the surgeon's actually able to look at other lesions that we might have just said, that's not a big deal. And so that's one of the reasons why just doing this in a multidisciplinary approach doesn't just have to be the surgeon, it can be anybody, but just talking about it with other people helps modify the treatment strategy. So what happened in Excel is interesting, and what's nice about this trial is that there was assiduous attention to detail at various time points with a lot of different endpoints, and so I think it gives you comprehensive information. It was clear that within 30 days, the outcomes favored PCI. Now, this is a laundry list of outcomes, and some of which you may say are not that relevant, transfusions and bleeding, but these things are important to patients, and in this trial, you see capture of these things. There are other things like atrial fibrillation, et cetera, all favoring PCI because it's a different procedure than surgery. Now, what about the primary endpoint? And the primary endpoint in Excel was a composite of death, stroke, or myocardial infarction at 3 years. And this was the initial 3-year data. Now, I'll point out a few things. First is that, remember, all of these definitions or all of these endpoints depend upon the definition of these endpoints. And in Excel, what was done was an attempt to capture all MI endpoints, paraprocedural and late. The reason for that was to be sure that all of these events were amalgamated together. Now, some have accused the investigators of trying to rig this in favor of PCI. And if you look early, you can see there's an increase in rates of paraprocedural MI specifically that drives this difference in death or MI or stroke at the early phase. The reality is these investigators, this was an investigational team of surgeons and interventionalists, all sort of came together and came up with definitions of myocardial infarction that basically picked up big MIs. But remember, if you take a more sensitive definition of MI, that will change the endpoint results as well. And I think those analyses are going to be forthcoming this year because those analyses, the good news, the data is there to actually capture it. Nonetheless, what one can see is that not only was there a difference early in favor of PCI, there was actually a problem starting to appear late. And that is the curves started to not only come together, but even separate. And this was a big question, but this was nothing new. Everybody saw these data and suggested that we need to have longer term follow-up to see if the curves remain together or they separate further in favor of CABG over PCI. Now, also importantly, quality of life. This is something that we don't talk a lot about with left main disease, but it's important to mention. Improved dramatically in both groups of patients, PCI and CABG, and it was similar out to a follow-up of 3 years. So here are the data, longer-term data, death, stroke, or MI at 5 years. And what one sees is that, yes, the curves not only crossed, but then started separating in the other direction, favoring CABG late over PCI. So where does this come from? Well, it all comes from MI. And this is consistent with the NOBLE results. And what you can see is that beyond a year, the MI rates truly favor CABG, and this is incontrovertible from this trial itself. Now, early, they favor PCI, and this is why there's a lot of controversy, because people will say that that's dependent upon the definition, and you need to show us all definitions. And as I said, those data are going to be forthcoming, and I think they'll hopefully be presented in a fully transparent way so people can address what's going on. But frankly, I have to be honest with you, as an interventionalist, as I said, I don't often check enzymes early in these patients. And so for me, if I'm sitting in front of a patient and they're sitting in front of me and I'm trying to counsel them on what to do, it's obvious that the upfront benefit of PCI in terms of being less invasive is going to be something enticing for the patient. But when I look at these MI data and see a difference in terms of late MIs consistent with NOBLE and in this trial, that's something that gives me a little bit of pause, and that's why we need to be circumspect and talk to patients about these differences seen in the trial. Now, the other issue of controversy within Excel was specifically relating to all-cause death. And if you look at death in Excel, the rate with PCI was 13%, and it was 9.9% in CABG. This difference, although not a primary hypothesis, does achieve statistical significance in favor of bypass surgery over PCI. Now, the investigators went further and tried to examine what the causes of death were, and it turns out that these are not all adjudicated to be cardiovascular death. The problem is adjudication is sometimes hard. For instance, a patient comes in, they have stents, they're on dual antiplatelet therapy, they have bleeding complication, and they die. Is that a cardiovascular death? Is that a non-cardiovascular death? Well, you could argue the reason they're on DAPT is because of the cardiovascular procedure. So these things are complicated, and that's why many people feel that all-cause death is the best way of looking at this. But what's unusual about these data is that they don't exactly match a lot of other trials that are out there looking at all-cause death. And so I'll show you one example of this. This is Syntax 10-year follow-up data. And remember, Syntax did not look good for PCI as a whole. But yet, when you look at the 10-year outcomes of PCI versus CABG, especially in the left main group, you see there's really no difference in 10-year outcomes and all-cause mortality. And that's to differentiate it from 3-vessel disease, where you see it clearly favors CABG with a positive interaction term, as shown here on the slide. Now, further, one of our fellows, Yusuf Ahmad, has put together these data and looked at longest-term follow-up from all of these trials together and what are the outcomes associated with them. And we published the first part of this in European Heart Journal. This has now been updated, and I'm showing you these slides. They're currently under review with the pre-Compat 10-year data, the Syntax 10-year data, as well as Excel, Noble, and the Boudreau study as well. And what you see is there's no real difference in all-cause mortality. Cardiac death, no real difference. Now, this is potentially an 8% increase, but the confidence intervals are wide. Similarly, there was an analysis published this week in JAMA Internal Medicine looking at this in a Bayesian way, although I don't think it included the Syntax 10-year or even the pre-Compat 10-year. I'll have to go back and check that. And what the author sort of stated was that if you look at it from a Bayesian way, although it's not 95%, the confidence interval, it's sort of 70 to 80% in favor of CABG over PCI. And that's a reasonable assumption to make. Remember, Excel was the largest trial, and there was an increase in mortality. But the question is for patients, is if you ask a patient if there's a marginal 1% difference in mortality, in other words, you have to treat 100 patients to save one extra life, what would they pick? And that's why it's important to put these things in perspective. Now, similarly, in this analysis, this meta-analysis, you see there's increased repeat revascularization with PCI compared to CABG, and MI also trends to favor CABG over PCI. However, stroke, it looks like there's almost a 25% reduction, although the confidence intervals are wide, specifically because stroke is relatively rare. And in the Excel trial, there was no difference in stroke, although overall TIA and stroke favored PCI. So what are the current recommendations for left main revascularization? I put current in quotes because they've not been updated with these data, and the US guidelines on the left of the slide haven't even been updated with Noble and Excel. I think you can appreciate that the source of a lot of anger among surgeons is the fact that PCI is afforded a class 1A recommendation, despite the fact that there's more late MIs, despite the fact that this mortality difference is there. Meanwhile, on the left of the slide, class evidence B doesn't make sense because these trials are now randomized trials. So where do I think the best compromise is? I personally, on the basis of Excel, and I was even saying this at 3 years, feel that CABG should be 1A and PCI should be 2A, reserved for those patients who either don't want to have bypass surgery or for those patients in whom bypass is deemed to be too high risk or some other factor for it. This is all comers. Remember, 80% of these patients had distal bifurcation disease. If you see osteal disease or shaft disease, I'm sure PCI is going to be fine for the vast majority of those patients. But if you see a generic left main, we at Columbia have not changed our practice. And what we take people off the table, we discuss it with the surgeons, and then many of these people undergo PCI later. Because remember, these are two very different procedures. This is basically the very simple slide that can show you the difference between the two. So heart team class 1, we think that that's really, really important. I think Syntax score personally is going to go away. I don't think many of you are actually calculating it. I'm certainly not. We look at the films together. We look at the complexity of disease. Now, a few other things to point out. Number one, operator volume and outcomes, really, really important to think about. And clearly now we have more than one study showing that at the same institution, in this case at Fuwai Hospital, if left main was treated by a low volume versus a high volume operator, there was a greater chance of dying if it was treated with a low volume operator. And just in the last week, we have operator volume and outcomes after unprotected PCI in the BISIS registry showing that the highest volume operators had the lowest rate of adverse events. So what do we do at Columbia? We double scrub. So we scrub with somebody else who is more experienced, and the person who's bringing the procedure always gets the credit for it, but we at least regularize the practice across our cath lab. Really quick on the end of the talk, PCI techniques for left main disease. As I mentioned before, even in syntax, the distal left main was involved in 60% of cases. We saw it was even higher in Excel and Noble. Remember that left main disease is a continuous process. And even if you see osteal LAD, IVUS will show you that it usually goes back into the left main as well. So there's plaque in the left main that extends into both branches, and that needs to be dealt with appropriately. Remember that single stent is often fine, and it's actually the preferred approach because even if it looks jailed angiographically by FFR or by physiology, it's often not physiologically significant. And generally speaking, we feel that less metal is probably better. There are studies like the DK crush studies that show that if you have true distal left main bifurcation disease, that a good DK crush may be associated with improved outcomes relative to other stent techniques and perhaps even relative to provisional, although some of those data are driven by the fact that in the provisional arm of those trials, they crossed over and went to two-stent strategy, and that's one of the reasons why they actually paradoxically noted a higher rate of stent thrombosis in the provisional arm compared to the double stent arm. IVUS must. Imaging is a must. Remember, it was used in up to 3/4 of patients in both Excel and Noble, and still we didn't completely match bypass surgery. So if you're going to stent the left main, you need to image. And you actually will change what you do. This is data from Akiko Mihara, who showed that when you IVUS, you actually change what you did 50% of the time. And that may be a different strategy. That may be more post-dilatation. It may be debulking or other plaque modification strategies. What are the criteria? I love this slide because Akiko is she's a small person. She's obviously Asian as well. And so there's a small person criteria and a large person criteria. Small person, 5, 6, 7, 8. Larger person, we're talking more about 6, 7, 8, 9. And the area that was seen in Excel that was associated with the sort of cut point of lowest incidence of adverse outcomes was 9.8 millimeters squared by IVUS. So it's probably a little bit less than that by OCT because of differences in measurement, but that's important to remember. Also, remember you have to IVUS at the end. Acute stent deformation at the origin was seen in 6.5% of patients in the Excel trial, and it was associated with an increased incidence of MACE. This is coming from the guide going in and out and banging on the stent, and so if you don't do a final IVUS run, you're not necessarily going to see this. Alternatively, I suppose you could just do a final pot and then be very careful with your guide, but this is an important thing to think about. So just in conclusion, first, I just want to mention that, again, despite what ischemia says, ischemia excluded left main, and left main disease is the only lesion subset for which revascularization is unequivocally accepted as improving survival over medical therapy until proven otherwise. So don't be fooled by what other people tell you. Controversies aside, the heart team approach is critical for these patients, especially given there's usually concomitant multivessel disease. Just unless the patient is crashing on the table, do the right thing, talk about it with the surgeons. Make sure your surgeons, though, are also amenable to all these different approaches, because there's some surgeons out there who just say, you need surgery, that's it, and don't even discuss with the patient the risks and the downside of doing surgery. And this is probably really relevant, especially now in a pandemic, where being in the hospital, being without your family and having a longer stay is a resource-intensive thing. And so we actually may default more in the pandemic towards the strategy of PCI. Operator experience matters, especially in left main disease. There are observational studies that clearly show this, and technique is important. Imaging and physiology, use them, especially imaging for sure. Bifurcation strategy and lesion perforation are going to be based upon imaging. And then finally, make sure you're attuned to hemodynamics with judicious use of support. Remember, Excel and Noble both had mean EFs around 60, so these are preserved. That's why they used almost no hemodynamic support. If the EF is lower, it doesn't mean you have to use it. It means that you need to think about maybe you should diurese the patient before doing the procedure, and maybe you should have it on backup, and in some cases use it up front if you're worried about compromise. So with that, I'm going to conclude. I hope that was helpful, and certainly I'm going to stay on so we'll have more questions after the talks, which have some cases as well. Thanks so much.
Yeah, thank you, Ajay, for an excellent talk. Actually, I was wanting to get that question about operator experience, other things which you have brought out already. And what I was also impressed with the Excel recent data is the first 1 month, there's a lot of advantage of PCI over COBG. So patients need to first get out of the hospital alive and to do perform better on the long-term follow-up. That was very clearly analyzed, and the subset analysis, I think we'll discuss more in the discussion. Sushil, you want to say anything before we go on to the next talk?
No, I think that's great. I mean, I think this data is great, and I think it's important to have the data. But I think the conversation, Ajay emphasized, the conversation with the patient and the heart team is not the surgeon and the interventionalist and the cardiologist, but also includes the patient. So if it's an informed decision, you know, the trade-offs the patient can make, and I think it's important to allow patients to make those decisions. But they can only make that if they're given all of the data in a way that they understand it. They're not, patients are not physicians, but these can be presented in a way that patients can make an informed decision and accept some of the trade-offs that they're going to take, whether they have open surgery or PCI. And if that's done, I think that's one of the things that I always consider is lacking among most conversations, is that the patient is not part of the heart team, and I think that's important.
Okay. Thank you, Sushil. And then now I'm very happy to present Dr. Samuel Matthew to you in our webinar. Indeed, I'm very happy, and he needs no introduction, but I would like to say he's the teacher of our teachers, and then probably Bhishma Pitamaha for interventional cardiology in the country, but still very active, like as young cardiologist as always. He, in spite of all these tough times, he's staying in a place where the internet connectivity is a problem, but a lot of things he could arrange for our sake. That is the interest he has for educating youngsters and training many juniors across the country. Thank you very much, sir, for your time. And we wanted to learn more from you regarding the calcific vessel disease, which you have pioneered from beginning, and the calcific left main as well as multivessel disease. My approach. This will be dealt by Dr. Samuel Matthew. And we will have questions again in the end, sir. We request you to continue to stay after the presentation too. Over to you, Dr. Matthew.
Thank you, Srinivas. Am I clear? Are you able to hear me?
Yeah, we are able to hear you, sir. Slight echoing is there, but we can go on.
Okay, thank you for the kind introduction. And Ajay's lecture was very enlightening, and that takes away, I knew that was coming, that the theory part and present approach, present decision-making process, he has very clearly explained. I will show you what we really face in practice and how to handle them, whether that is going to be long-term beneficial or not. Unless we have a randomized trial, we will not be able to answer that question. So I can come out of all the studies, all the work I have been doing, I've been able to only predict what is the outcome immediate and midterm, but long term we don't have any comparative data to teach you or give it to you at the present time. This slide is familiar to all of you, that the thickness of the calcium is very important. Unless if the thickness is more than 500 microns, we have to have some other technology to address it before we get an optimal result. Today, the technology has totally changed. We have moved away from total debulking. We are only doing plaque modification to facilitate procedural success when treating the complex lesion, enabling lesion, and so we can enable the lesion success. What we are doing is making the complex lesions to a simple lesion, changing the lesion compliance, minimizing the vessel trauma, and creating larger MLDs. But it has not been demonstrated to improve the late outcome. I want to emphasize on this point. We are only improving the success rate and getting a better MLD. but we don't have enough data to confirm that late outcome is modified by this technology yet, because we don't have the data yet. Now, some points which I want to mention. Conventionally, there has been recommendation of using heparin, nitroglycerin, verapamil. Nitroglycerin, verapamil, and diltiazem, or various combinations have been used in the flushing solution. To me, this has been having a lot of disadvantages. Hypertension is a major hassle. Increased bleeding complication has been seen. Slow flow. Increased bleeding. These risks have been reduced, but all this endeavor to reduce the slow flow, no flow has not been changed with or without the flushing solution. Today, I would recommend that there is no need to use any of these combinations of heparin or nitroglycerin or vapor. Burr size, in my practice, the majority, at least 60%, is 1.5 or less. And there is only a very small percentage of more than 2 millimeter burr. And step-by-step burr approach is only 10%. Adjunctive use of cutting balloon or angioscalp is very often used to improve the result, especially in larger vessels. Coming to the issue of the RPM, the current recommendation, as all of you know, is 130,000 to 180,000 rupees. But at various times, we may have to change this recommendation. There are several situations when we are not able to cut through long lesions. We have to increase the RPM even up to 200,000 to get the flow back in. If you keep on cutting at low RPM, we may produce sludging of the cut material inside the vessel, and once you go through, it will all go and block the distal vessels. This is necessary to reduce the cut particle size stagnating in the vessel. Ablating technique, now I know all of us have changed our technique, and just to mention few points, over-tightening of the Y adapter creates a lot of issues because of that can damage the whole system, and never advance a rotating burr to a point of contact with the guide wire radiopaque area. This is just to mention, to remind some of the youngsters. This is the technique I had developed about 15 years back, single operator technique using both hands and able to advance the burr using this technique. This has been found to be extremely useful, and we have some advantages. Loss of rotor wire position is reduced to less than 2%. Loss of guide wire position is only 1%. Loss of guide wire and catheter, both during dynaglide retrieval, is also less than 1%. Complications of slow flow, increased CKMB rise, non-QMI, QMI, dissection, abrupt closure, all these things have been definitely come down by using the modified technique what I just described. Rotablator had been showing a decreasing trend. Decreasing trend in the late half of last decade, and now it has picked up, and I feel it is going to stay as it was. Just looking at some of the pictures, I'm sure all of you looking at this picture, the surgeon, of course, saw this patient and said the LAD is not graftable. He wouldn't recommend surgery because the whole artery is diffusely diseased. The circumflex is graftable, but we jointly decided that that's not the answer for this patient. we decided to take her up for angioplasty. Did a rotablation of the entire length of the LAD, and proximal part of the circumflex was treated with a cutting balloon, followed by stenting of the proximal segment of the LAD, and the distal segment was only POBA beyond the stent. At this point of time, this is about 2000, I think early 2000, 2001, yeah. That point of time, we never knew what would be the long-term outcome. We managed to follow up this patient for a long time, and 3 years later, we did a restudy. To our surprise, this is the final result which we had sent the patient with, and this is the follow-up angiogram after 3 years. If you look at this picture, you see the artery, the left system, the LAD as well as the circumflex have positively remodeled itself and became, now a surgeon would say, yes, these are graftable vessels. What we did was only to modify the plaque and get the flow re-established in a patient, and it did work well. This is all anecdotal examples, but if you have proper long-term follow-up, probably this may work out well for others also. There's a patient with a lot of comorbidities, distal LAD, proximal LAD, proximal circumflex, just starting from a dense calcific ball, which is at the distal end of the left main. The main challenge here is which one to rotablate first. If you rotablate one artery, will the other artery shut down? These are all possibilities, but I can tell you that in my experience, if you can rotablate properly and not jamming the burr into the vessel, they do quite well. Here we got a rota wire into the circumflex first, which is technically more challenging, and which was followed by rotablating the LAD, and the final result outcome was this, what we got post stenting of both vessels. This is a patient, unstable angina, 81-year-old, lots of comorbidities, weighing only 36 kilos. The surgeon said there is no way he would operate, and LV function was significantly compromised. This we did live for one of the India Live sessions in 2014. We got a rota wire into the LAD first, rotablated, re-established the blood flow there, then attempted the proximal circumflex. The distal circumflex at the level of the bifurcation, you can see it's a thrombus. We avoided during that section, and we stented this segment. We did a fairly decent job, got a reasonable result in both the vessels, and patient did well consecutively. There are some situations where we see calcification in the proximal vessels and in the bifurcation. Here, this is a patient who had calcification of the entire left system. We rotablated the LAD first. That is standard, that's a decent result, but when we came to the circumflex, you can see the proximal calcification at this level, at the mid-level before the bifurcation, but then we had to use a rotablator. We got a rota in. To our surprise, the rota did cut the proximal end, but it wouldn't go any further. It got stuck. Even a second 1.25 bar, this is a 3 minutes cutting time. Then we changed to a second 1.25 bar, but still it wouldn't cut. And we upgraded this bar to 1.5. Again, same situation, bar not crossing. What we did is we managed to get a 1.5 compliant balloon across, followed by a OCT catheter to see what exactly is happening there. We got some additional information after getting the OCT. OCT showed the proximal part there was calcification, but distally, just before the bifurcation and at the bifurcation, it was only fibrofatty plaque. the fibrous plaque was not yielding to rotablator. That was the reason, and we did get an optimal result with just ballooning that segment and stenting. And you can see the OCT picture post-procedure. We got an excellent result in that. So there are situations when there is proximal calcification distally, we may think that we can use the same birth to get a reasonable result, but we won't. Then we have to change our strategy. There's a case, as Ajay talked about, the patient who has got a distal left main, ostial left main, LED is totally occluded. And the surgeon said plus or minus, we can try. We don't know whether the LED is graftable. We weren't sure. We said, okay, we'll try. If we can get across the LED, then only we can attempt the left main. Otherwise, we shouldn't, because if you don't have a good antegrade flow, we shouldn't attempt treating the left main at all. We tried to engage the guiding wouldn't engage. We got a guidocilla to engage the left main, and you can see we are trying to get a wire across. Only wire which would cross the lesion was Contrast Pro 12, but no balloons, no other devices would get across the distal calcification. We pulled the wire out and replaced the wire with the Rota wire. We managed to get the wire down into the distal part of the LED and then rotablated the calcified segment. Now, once we re-established the good distal flow, we were sure that this patient is likely to do well, and then attempted the left main and treated and did well with the combination of flextome and multiple balloon dilatations and long DES in the proximal and mid segment of the LED and left main stent. This is the final result. So in such cases, unless we are able to establish a good antegrade flow, I would strongly recommend that that patient should not be attempted with PCI. There's another patient, a very similar situation with the LED total with calcification. We managed exactly the same way with the crossed with the Congress Pro and pulled that wire back and rewired the LED with the Rota wire, rotablated. You can see with the 1.25 bar, finally we managed to 1.5, 1.25 bar, we managed to go across the lesion. Rota went through, we are very happy, but it was very short. The wire was cut at mid-segment. This is some complications which can happen with calcified vessel, where we have to do long cutting using the burr at the same point that will make the wire very supple and that can break at that particular point, which will be technically challenging to get we will never be able to get the wire across, but we managed to get a covered stent. You can see the perforation. It was contained perforation in the myocardium. We got it across and the antegrade flow was re-established. Now we have started using more and more other devices, especially the lithotripsy, a very, very interesting case we came across, which we did for India Live 2019. There's a patient who had multivessel disease, circumflex total, RC diffuse disease with multiple narrowings, including the bifurcation, and LAD had long segment calcified disease. Rotablator was used for the both circumflex and LAD and got a reasonable result in 2019. This is see a tubular lesion and the circumflex we managed, and this was the final result we got in 19. patient did well for 1 year. 2020, February, patient came back with a lot of symptoms. When we restudied this, the picture we got. All the stented segments are doing well. The proximal calcified segment has progressed, and it is from the left main ostium. You can see the lesion here. So what do? We decided that we can probably try a lithotripsy balloon, which was taken up on 2020 February. We used a lithotripsy balloon, gave, I think, 4 cycles in the LAD and 2 cycles in the circumflex. We got, if you look at the post pictures, there's a shockwave treatment being given for cycles. You will see something very surprising. What we saw was at 4 atmospheres, we saw an aneurysm formation coming up in the proximal LAD. I haven't seen any report of aneurysm formers post shockwave delivery, and this is what we see. And now is here. He can comment later probably. Looking at that picture, we were really surprised. We post dilated, then used stent. We thought while stenting it would look better, but to our surprise, it didn't do well, including post-stent. So we can deal with lots of lesions, lots of difficult subsets with combination of with the calcification, with combination of multiple devices, what is available to us. But this is only talking about present, post-procedure, immediate. Long term, whether these are likely to do well, we have to only follow them up and get the data out. I don't have the data to confirm that these are the method of treatment which we should follow. But when we have no other options, when we have comorbidities, when the surgical team is not willing to take charge of those patients, that subset, we have full justification in treating them and giving them some relief to what their symptoms are. And in my opinion, the technique has evolved as far as Rota is concerned. Most of the earlier studies were at the time when the technique was quite primitive. Earlier, the burr was just jammed into the lesion without looking at the RPM drop, producing significant thermal injury. We now never allow the burr to contact long enough to allow the RPM to drop more than 5,000 to produce thermal injury. Patient picking action, constant movement, never allowing the RPM to drop is an absolute must. IVL, we are still learning. The initial experience appears to be promising, but it also has its limitations. As Ajay said, with meticulous planning and strategy, we can tackle many of these left main as well as the calcific vessels in left main as well as the multivessel disease. Familiarity with the hardware and fair learning curve, Rota actually significantly reduces complications. Not using rotablator often leads to longer and much more difficult procedure. The cost balances out because of the use of multiple balloons and other hardwares. Finally, be quick to adapt. Slow flow and no reflow can be minimized and managed. Major complications with good technique in calcified lesions are very, very rare. So primarily what we need is a good technique and good proper strategy planning. Thank you very much.
Thank you, sir, for the excellent cases and showing the principles of preparation with rotablation and also covering up the latest shockwave lithotripsy balloon regarding. I think both are little complementary to each other rather than competitive. I think we can discuss more about in question and answer session. What I keep telling this because we have stents have made us very competent, and from the stage where we used to take surgical standby, now we go procedure by standby, and we are in a position to help our surgical colleagues. I think I'm sure Dr. Matthews and Dr. Praveen would get about 1/4 of their referrals from surgeons, where surgeons are not able to revascularize, and they request us to do some sort of palliative procedures. I think we have come a long way from earlier part of when we were students to now, where we are in a stage to help surgeons. I think only thing is, as sir said, we need to have more good long-term data. That's what we're in the process of collecting. And Sushil, you want to say any comment before we go on to the next talk?
I mean, I think those are great examples. And I think it's important to keep in mind those case examples are from experienced operators. So all those cases will become, an inexperienced center, inexperienced operator, because again, it all depends on what the expected result is. But I think probably what that's a question for Ken, when we've had a discussion on the imaging and sort of bring all these questions together, because people have posted some interesting questions regarding imaging, left main, and other things as well. So maybe if we move on, then we can come back to this later.
Yeah. I think the only thing is the youngsters who are watching this webinar don't attempt to do such complex cases straight away. I think it comes with a lot of experience, and we need to do very simpler cases before people go on to such complex stuff, which Dr. Matthew Samuel sir showed. Now we go on to the next presentation. This would be like the OCT image guidance of left main intervention. I would feel happy. I thought I would specifically mention about Abbott here before this goes, and we are extremely thankful for all the people of Abbott management, especially Subodh, Anil, and Jaspreet, also in spite of tough times and being sick times. And they've helped us and coordinating this entire program and sponsoring this. And it's country's fortune also that OCT is being handled by Abbott. When and we wanted somebody good to speak about this technology. So we were wanting to have an expert from Italy, Europe, and again, Abbott made this possible. And we are extremely thankful to Dr. Giulio Guagliumi. Other worry in my webinar, what I had is how to pronounce this doctor's name right. Hope I pronounced it right. And we thank you.
It's perfect.
Yeah.
It's perfect. I'm so pleased. Yeah. I'm so pleased to be back to India. Despite the fact that it is a virtual journey, I'm very pleased because we are restarting, connecting, and that is an important step forward.
And let me tell you, he's the director of interventional cardiology in Hospital Papa Giovanni in Bergamo, Italy. That was a hotspot for COVID cases, where all this live transmission of TV coverage and all was happening through his hospital. In spite of all these tough times, I think they're trying to establish. Thank you, Guelio, for giving us time. And we would like to hear more from you on the OCT imaging of left main interventions. Personally, we are also getting more and more fascinated with OCT imaging. We were, though, thinking in favor of IVAS before. The crystal clear pictures which OCT gives, I think for it is easy for beginners also to learn it, and would hear the pros and cons of it in the left main interventions. Over to you.
Thank you very much, Srinivas. I'm going to share.
It may have been that his browser.
Okay, that's right. Okay. Can you see my screen?
No, we can see you and hear you, but we are not able to see the slides. I think you need to share screen.
You did before.
Sometimes, are you using Chrome or which browser are you using?
I'm using Chrome.
Coming.
Yes. There you go. Perfect.
Okay, good. So topic is left main imaging by OCT with cases. Here you have my full disclosure. There are many reasons, anatomical and technical, why we should have a low threshold recommended by also Jay for using imaging in left main coronary artery. A couple of the major are the highly variable diameter of the left main and the difficulty in sizing. The second is the same for the highly variable bifurcation angle and the circ and the diffusion from the left main into the major branch. And then we have technical difficulties. For instance, it's difficult to evaluate the angle of the circ and take off. And then many times we might be in trouble with a guide wire going behind the stent. And for sure, especially at the bifurcation, the under expansion malposition can count on outcome. What is the value of intracoronary imaging in a left main coronary artery disease? Here you have 4 different bullet points. And in bold, I was identify the potential help and plus of OCT compared to the other vascular imaging. For instance, in decided if to revascularize or not, if it's needed, so you can meet many ambiguities, and we will see some example soon. Then when you are planning the optimal stent strategy, you wanted to know about the stent extent, the type of involvement, and we heard already the critical role of calcium. Another possibility is to try to identify and correct complications, and the plus for OCT compared to IVUS could be in edge dissection identification and rewiring the jail side branches. And finally, if you wanted to improve the patient outcome based upon imaging, you needed to optimize the expansion. That is not only a matter of sizing, but is also a matter of apposition and guiding the complex reintervention in case of failure. We learn a lot from IVUS. We learn that despite the declaration to use so frequently IVUS for guidance of the procedure, in many cases you do not see the proper use of the imaging technique. And the proper use is based upon not only imaging, but measurements. And the measurements can be practically applied to the left main for detect from where to implant your stent, so the landing zone, and then also to guide the size of the stent and then guide the pot intervention. OCT is doing more or less the same. Number one is try to identify which are the appropriate landing zone, differentiating tissue. And you can see that we can move from what is suitable, normal or fibrous, to what could be acceptable, calcified with a larger lumen, to what is unsuitable for landing your stent in any type of a segment that is lipid rich. So the precise PCI is based upon the identification of the tissue. The same that IVUS use is apply in OCT. So if you don't have a burden of calcium and you have a lipid or fibrotic, you can decide for direct stenting. Instead, if you have a low calcified burden with a mixed plaque and a deep, you can go with a different strategy. And the more you are increasing the complexity and the level of calcified nodular or concentric protrusion, the more you need to be aggressive in a lesion preparation. What should be measured? Number one, the dimension of the left main. Here you have one of the basic notions. Left main is not a cylinder. You have 70 cases assessed by CT scan, and you can see that the shape of the left main can be completely different in terms of to be biconcave, to be tapered, to be combined, to be funnel. Here is what you can perceive by using OCT in terms of ellipticity. You can see that you can be quite help in getting a full apposition when you have this type of symmetricity, and to be really in trouble when the ellipticity index is increasing, to try to have the stent expanding without malposition. So the first message is OCT cross-sectional analysis of the left main demonstrate elliptic shape in a significant percentage of patients. To get a final circular geometry and prevent a Strauss malposition, by conventional means is just wishful thinking for them. So do it pre, not just limited your use of imaging to the post. OCT is feasible in the left main, and perhaps is possible more accurate than IVUS in the distal left main, but there are technical issues. And one of the technical issues is that you can be in trouble in assessing the ostial left main or the very short left main. And there is a clear explanation why, because you have to engage the catheter, and you have in any case to sit in properly the catheter. The catheter selection is extremely important. It's no by chance. And then when you look at this data, you can see that the more proximal you are coming to the left main toward the ostium, the more you might have the segment and the frames. They are not clearly available for making measurements. They are more rich in artifact. The more you are leaving the ostial position, and the significant level of reliable measurements is dramatically increasing. So you can get the best in assessing the body and the distal part of the left main. Is always tenable, this concept? This is one exception. I did with a friend at the Apollo Hospital in Bangalore last year. Here you can see diffuse vessel disease involving also the ostium of the left main in LAO. What to do here is what was done. So we were sitting the catheter gently really to the ostium. We did one scan that was quite difficult considering the diffuse of disease. And then you can see here is the bifurcation, clearly explained. And then we had this nice cross-section that was almost intact. And you can measure the EL to EL diameter of the left main. And then you can see this funnel shape of the left main fully invaded by pathology that was very high lipid rich. You can see the signal was attenuated clearly around the entire circumference with just this nodular of calcification. So we did what was suggested by the measurements, implanted a 4.0 post-deal 5.0 based upon the size that was measured, and this is the final result. And this is what you can get. You can get a full apposition. Here you have the apposition bar with a no malapposition. You might see clearly that you have a very satisfactory expansion, and you are divided in two different segments from the ostium to before the bifurcation, the stent for assessing the expansion. Of course, in this lesion, you needed to remember that large vessel, frequently more than 4 millimeter inside, are bringing the risk of blood contamination. And then there is no validated MLA cutoff for ambiguous left main assessment. And then for diffuse left main disease, the OCT cannot be ideal because you cannot visualize the EL, and so you have a limited disease assessment. So in any case, ostium, in my view, and the short left main is for IVUS instead for OCT. If you wanted to do it, there are tips and tricks to be successful. Avoid very aggressive left main cannulation, selecting properly the guiding catheter, then check and seat the catheter position in LAO view, increase the field of view, improve the flush quality, coaxial injection, check the imaging before the pullback with a puff of a 3 cc through the guiding catheter. Don't do it the pullback if you have a blood contamination. Try to get a proper contrast injection with no blood during 3 cc, during 3 seconds of the pullback. And the injection, David, should be in between 3.5 and 4.5. What in addition? Well, when we are moving from the ostium, we are dealing very frequently with a bifurcation and with what we call ambiguous lesion. Likewise, in this case, very clear TAF lesion in the D1, but unclear lesion on the proximal LAD. And what about the extension in the left main? Here you have a very quick scan, and in a couple of seconds, you have full of information. You know that, first of all, you don't have any calcium inside this vessel. You know that they are full of lipid, and you can clearly see. But in addition, you can see also that at the level of the left main, where you have a moderate stenosis, you have an orphan plaque that is plenty of lipid with many multiple cavitation closer to the surface that very frequently are linked to the hemorrhages. Here you have the way normally we are dealing with OCT and ambiguous left main involvement. This is a single lesion on the proximal LAD in a different view. Here you can see the pullback, and in this pullback you have the automatic detection border when you have the profile from the left main going toward the bifurcation at this level, and you started to see that there was clearly this funnel shape due to the some involvement, then a very long lesion, and you can identify the landing zone for the distality. So in this case, you have the distal reference, you have the proximal identity at the level of the left main of the type of plaque that is involved in the left main, and you can also detect the tightest lumen area, the fact that the calcium was very marginal, and the length of the stent. Here is doing provisional stent, then KBT, and then POT, and here the final result. One additional scan, you are informed about the full acquisition. You can see the rendering of the stent with a different cross-section, and you can divide the multiple segment and assess the expansion of your stent. This is the 3D view, provisional stent KBT, and you can see how nice was the opening of the circ. So I think that basically OCT is great for left main bifurcation assessment. It's telling you many different stories. It's telling you about the protrusion eventually of the carina. It's telling you on the opposite of flow divider, where is the plaque and which type of plaque do you have, and possibly is identify additional apparently normal segment of the left main. They are involved by the plaque, and you can take measurements. So Ajit was very clear that we are dealing with an issue, and the issue is clearly at the level of the bifurcation. Data divided by segment, so lesion side coming from the Excel, you can see no difference when you are excluding the bifurcation between PCI and surgery, huge difference when you are involved in the bifurcation. And we know already from IVUS that if you wanted to gain the benefit from imaging, this is the setting where we can use much more intensively. The distal lesion with the plan 2 stents are the ones where you can see more clearly the difference in terms of outcome and major events compared to the angio guidance. Where we are with the OCT. This is the study that is extremely advanced. October is 1,200 randomized patient one-to-one OCT guidance versus standard guidance, left main or not left main bifurcation with a major side branch, and the primary endpoints were clinical. Which type of dealing we have with this imaging strategy is to make a clear step-by-step what should be done. And that is very challenging because you are facing multiple situations. We needed to wait a little bit more to see these very important results. What about calcification? Here you have the same patient, pair cross-section at the left main level, showing the difference between IVUS and OCT. And here you have one of the evidence how we are using this technology for making judgment of our procedure. So very calcified left main vessel. We are assessing calcium assessment we are assessing the lesion with the assessment pre-implantation. You can see the angle, you can see the lumen, and here you can see the thickness of the calcium in addition to the length. Based upon this different aspect, we are deciding to go with a rotational atherectomy. Here you can see clearly how the technology is showing the effect after 175 burr, and here you can see how much is changing the lumen profile before compared to the first burr. But at this point, having still a lot of calcium behind, we decided to be more aggressive. We went with a cutting balloon. Here you can see the effect after aggressive cutting plus decay crush and a high pressure pot. And despite the fact that we crack the calcium, here clearly identified by the dots, you can see how much suboptimal is the results using very aggressive technique. So the message are, number one, to do OCT or imaging in any case before, to judge and to plan your procedure. Second, to try to understand how much you gained during the procedure to optimize your implant. And here you can see from the forward view, from the backward view, how much the calcium is distorting this left main stent done at the best of the technology with a decay crush. What about the comparison between OCT and IVUS in terms of a post-PCI? In terms of measurements, they are very similar, no big difference. In terms of plus, you can gain something for malposition and distal edge dissection. Here one example of a single provisional stent seems good in terms of angiographic results. Here you can see a dual layer dissection distally with a quite a large angle, and here you can see the malposition identified in the cross-section and by the rendering of the stent in the red. Of course, when you are going toward the more complex dual stent implantation, like the decay crush, you need to judge the results. This is a case with nice angiographic results, but with an horrible protruding carina and stent distortion at the level of the bifurcation. Based upon this imaging, we went back, and obviously some clot forming immediately. We went back, we rewiring the circ in addition to KBT and POT. Here you have the angiographic final results, and here is the second pass, when you have a much more neutral carina and much better expanded. So one of the potential plus of the OCT is in rewiring properly the cells. It's no obvious. You need some training and you need to spend some time. This is the number of guide wire recrossing, but in any case, you can be quite successful in getting the proximal or distal where you want in terms of rate. Finally, I wanted to address this possibility. So it's not only at the time of implant, it's also at the time of a failure that you can dramatically benefit of this imaging. This is the case with the 2 stents implanted in the LAD and the circ, coming back with this severe restenosis involving the left main. This is the pullback showing how underexpanding was this stent at this level compared to the distal referent, the proximal one. And this is from the circ, the same, plus a huge amount of growing tissue. And based upon this and the knowledge that we have on the type of tissue, we decide to make a different type of approach for re-expanding and finishing the procedure in this way with a very nice position. This is the last case that I wanted to show because sometimes the people say, well, yeah, but if you are in trouble and if you have an emergency case like this one, you cannot do OCT. This is the way we can do. Number one, be simple. So we went through a pre-deal of the distal left main, and after the pre-deal gentle with a 2.0, we did a simple longitudinal scan. Simple longitudinal scan showing what? Showing that the type of the lesion, no calcium, is allowing you to take the measurements of the 2 landing zone proximally at the left main level and distally on the LAD, and to try to make the best of possible. These precise measurements in this case was also scaled to the local anatomy. Only 1 single stent available. So based upon a compromise of EL, we selected 3.048 and we finished the procedure in this way with a single stent. So my last message is I don't like to stay blind in decision when I'm dealing with the left main. But in this case, imaging must be used before and after. Which type of impact we can expect? I think imaging is positive overall to the result of left main PCI, particularly for distal lesion and mostly when you are treated with a 2 stents technique. But you needed to keep in mind that the study supporting IV imaging guided left main PCR are based on IVUS. And we are still trying to catch the delay with the OCT finishing this very important study. OCT is not suitable or less suitable for osteal lesion of very short left main and more technically demanding. But OCT is superior for calcium, cell wiring, detection of dissection, malposition, 3D bifurcation assessment. I think that the most important point is to recommend in left main for both to have an accurate planning pre-procedure, making measurements, and post-stent evaluation. Thank you very much.
Yeah, thank you for the excellent presentation, case-based discussion. I think we are running slightly behind the schedule, and we have Dr. Praveen Chandra with us. He has other commitments too. I think all of us know him, but as a customer, he is the chairman of Interventional Cardiology and Structural Heart Division in Medanta Heart Institute, one of the leading institutes which are in Delhi. And we wanted him to share his experience of left main interventions. And over to you, Dr. Praveen Chandra. But unmute your mic now.
Okay, I am unmuted. Thank you, Srinivas, and these were wonderful presentations. I think almost everything is fully done. So most of the things of left main have already been said. So I will share some cases, and of course, we will see if if it is interesting for everybody. So I'll share my screen now, and application window. Okay. Yeah, it is coming up. Yeah. So, can you see my screen, Dr. Srinivas?
It's just coming up, sir. Just half a minute.
Is it there?
Not yet.
Not yet, because I can see the screen. I don't know.
I think Guglielmo
Guglielmo has to Unshare, I think.
Top share, I think. Then we can.
Yeah.
The tech team
Has he
put
unshared? Hello.
that Julio, please unshare. Stop sharing your screen. Then it'll go on to Praveen.
Maybe Praveen, you should stop sharing as well,
Okay. Okay.
and then share again now, maybe.
Okay. So it's unshared now. So I will share it.
We are learning new techniques in webinars also, like in interventional cardiology.
Yeah.
Coronavirus is teaching us a lot of new things too.
So can you see my screen now?
Yes.
It's coming up.
Now we see
Yeah,
it.
we can see it.
Okay. Yeah. Okay. Yes,
I don't know.
Srinivas, can you see the screen?
We had it again. It became black.
I don't know why it is happening this way.
Now we can see it. We can make it a screen show.
No, actually, when I make it the screen show,
It's disappearing.
it's black. Is it okay?
You can do like the previous one only. Fine.
Okay. Okay, but the this one will not. Okay, let me see why it is happening this way.
I think it might be that you're going to presenter mode or something, is what the tech people are saying. And they're saying share screen, not through the application. Don't share the application, but share the
Yeah,
information.
now we can see it.
That was good.
Perfect.
Now it's okay?
Yeah, perfect.
Okay. So now quickly, let me take you, I mean, this we have already discussed when to treat the left main, and of course, there are so many clinical and angiographic guidelines which are available from European Society and also from the ACC. So we can use all that. So basically, based on this, we have all kind of cases which come to us on a real life basis. Not all are complex. Some are complex and some are non-complex. And I can say that, about 50% of the patients of left main are really very simple. Let me just put it this way, especially the ostial and the body of the left main. So the more complex are the ones which are, as Dr. Matthew showed, very calcified lesions or the distal left main bifurcations. And of course, those patients who have, other diseases in, the distal part of the circulation, being the LAD or the circumflex, and sometimes also the right coronary artery. And also the complexity increases when the supporting circulation is not there, when we start thinking of having a hemodynamic support in these patients. So based on this and based on the information to improve the outcomes, as Dr. Julio already said, that we can improve or optimize our outcomes or taking the right decisions can happen when we use IVUS or OCT in these patients. So the decision-making process becomes much more accurate, and both in terms of starting what has to be done and of course getting the final outcomes in these patients. So these are, I think the data which we already have gone through. Dr. Julio and also my other colleagues have shown that using imaging is helpful. And as you can see here, so many trials, all in terms of MACE, cardiovascular death, MI, and TLR, all are supporting that yes, using imaging is a good idea in these patients. And basically what we look at is that we minimize the dissection, we minimize the protrusion, and also minimize the malapposition, which is a common thing in left main interventions because of the size of the left main artery. So then the next thing is, after you have decided to take the case, is which kind of technique you want to use, because there's so many techniques now, and so we can choose either of them, but that decision has to be very initial stage. We have to make a plan that we want to use this particular technique in this patient, whether it is a single stent technique or a double stent technique or or a V stent or a SKS technique. So all these things have to be decided upfront, And that all depends upon very careful examination of the angiogram and also sometimes the intravascular ultrasound or OCT pictures. So that strategy making, I personally believe, is a very, very important thing in left main interventions. And the idea should be to make it as simple as possible. And one should typically, this is also one of my advice and also my take on left main PCI is that we should try to make it non ad hoc as much as possible and keep it as simple as possible. Otherwise, the complexities can lead to more complications. That we already know. A lot of data is already available. So basically, first we should think, plan, and then only go for the action. And the steps of the procedures, the hardware required, everything should be made available, because sometimes we may require a IVL shock wave, which is now available. Sometimes we need a OPN balloon, which is a ultra high pressure balloons in very calcified lesions, or we may need a bigger guiding catheter, 8 French or so. So all these planning part should be done much earlier. And in some patients where we think that the patient may be hemodynamically affected at some point in time, having a standby balloon or a standby impella is also a good idea in these patients. So every armamentarium should be ready in the cath lab, and one should be knowing what are the consequences and how we are going to deal with this problem. So that is my way of handling things, especially for left main, and generally try not to do on a ad hoc basis. And as today morning only I was discussing with Srinivas, we had a patient yesterday who had a tight LAD, very tight ostial proximal LAD, and a lesion in the left main. We thought to refer to surgeons, and in the morning the patient started to become very unstable. So we had to do a procedure in this patient with an intra-aortic balloon pump already put in before I started this procedure. So those are the things which we have to keep in mind before we take these patients up. So take as for example this patient, you see. This patient comes with significant symptoms. The angiogram doesn't look too bad, and we are not sure what is happening. There is some lesion at the distal left main. So now the lesion looks simple, but the procedure will be complex if we do it. So first, before we do this, we assess it completely by doing a FFR and a OCT. As you see here, FFR was significant, and also in the OCT we wanted to know the nature of this plaque. And as you can see that to start with, the lesion was not looking so tight, and you see that this is a calcification distally. And now you come to and this is a co-registration. You can see that the proximal LAD looks reasonable, but ostium is very tight, and the lesion is extending into the distal left main. And this is the proximal part of the left main. So now it is very clear that what we are going to do, whether doing this procedure is a reasonable idea or not. So doing this imaging was quite helpful, and also looking at the lesion, it was clear that doing a single stenting, keeping it as simple as possible, would be absolutely reasonable, and even the wire can be put provisional in this particular case. So we do a stent which is from the left main to the LAD, and as you can see, there was a lesion there which gave way at beyond 12 or 13 atmospheres. Then we do a post dilatation, and after the post dilatation you see that the circ is flowing fine, because it was a T circ and also not having any significant disease. So we never put a wire in this kind of situations, and the procedure remains quite simple. And you can see that we do a post dilatation to high pressures with a 4 millimeter balloon proximally into the left main, and thereafter the result looks quite okay. And this is the final OCT run of this patient. So basically if pre-planning and then of course taking the right steps and making things simple is the key to success in left main interventions. So you can see that there are some little there was a malapposition proximally, which was further again dilated with a 4 millimeter balloon to very high pressures, which went up to 4.3, 4.4. and led to a reasonably good result. Patient did very well after that. So another patient, as you will see, that this patient has a very bad LAD, and the lesion is extending. The lesion is extending right from the distal left main going into the mid LAD. So we have to make a plan. We cannot just do ad hoc these kind of cases. So we say, okay, this is a calcified lesion. There is a lesion in the RCA distally, which will be dealt at some point in time. But this one, we go ahead, we do a rotational atherectomy because we know that this LAD has to be treated well, and putting a IVL in this kind of situations becomes tough to start with. So we thought, let's do the Rota and then see how the lesion responds. If it doesn't respond still, then we might use additional IVL in this case. So we do a Rota, and then followed by balloon dilatation. We find that the lesion is not still opening up. So we do another bigger, 1.5 bar, and thereafter we start dilating with the high pressure balloons. And at one point, the balloon was not giving way. However, with a smaller balloon, which was a focused pressure, we could dilate this whole lesion. And now you see that the artery looks okay, and we had already spent so much time, so we were almost at the verge of saying, let's leave it alone, it looks okay. But of course you cannot leave this, and then we take a buddy wire here, and after this a cutting balloon was done in the distal part so that we further dilate it more. And after that there were stents which was implanted into the middle of this LAD, and you can see it is well expanded. In the proximal part, we thought we will assess and whether we still need to put a stent there or not. So we did a OCT, and the OCT showed that the distal, there was a small dissection. You can see this dissection, which is beyond the stent. So certainly this will need to be treated. And proximally also, there was a dissection, which is understandable because there's so much of intervention was done to this patient. So this here you see that the stent is hanging in the middle with that aneurysmal part of the LAD, and so both the proximal and the distal showed dissection and a flap. So we thought that we'll have to put a stent going into the left main. So we put a 2.5 stent distally, and a proximal stent was also implanted, which is a 3.5. And finally, the OCT runs are being made after the final dilatations, both proximally and distally. And now you see the dissection is gone, and this whole stent now starts looking quite reasonable, and the final outcome looks okay. So basically, in left main, we have to assess what more we are going to treat and how do we address the whole thing with this adapting all the armamentarium, all the technology to get the best result in these patients, because most of them are complex patients. So I'll quickly go on to this, the final result of this case. As you can see, looks quite good. And so finally, we did so many steps: 2 Rota, 1 cutting balloon, 5 balloons, OCT, 3 stents. But of course, the most important thing is that you have to have patience and give time to this kind of patients. Then only one will be able to get good results in these kind of cases. Again, a similar patient, very complicated. You see that there is almost a kind of a ruptured plaque at the left main ostium, and then there is a disease in the LAD going from the proximal to the mid. So it's all long disease in the whole segment, and this all has to be treated together. So circumflex looks okay. So first we, as you can see that since the circ is so good, we don't again put any wire, nothing, and then we go straight forward, do the balloon dilatations, and then start putting stents from proximal to the distal. So here the only difference is that we do from proximal to distal because we are addressing the ostium of the left main, and that is why we do the ostium of the left main, and then distally extend the stent into the LAD. And that's how we get a reasonably good outcome here, and do a OCT in this kind of cases, always to see how the results are. And of course, when then we have lesions like this, where you see some plaque is there in the left main, distally and extending into the LAD and into the ramus, then of course the strategies will be slightly different. And in here, what we do is we start with the first putting a stent in the LAD with a wire in the diagonal, because there was a big diagonal coming off the LAD in the distal part. So we do that first, and then we put these, as you can see, post dilating these the stent, and then put another wire into the ramus and put a second stent there. So this is kind of doing a provisional stent or a provisional wire and then a stent into the two bifurcations. One, the LAD diagonal, and the second is the LAD ramus bifurcation with the distal plaque into the left main. So we have to kind of make improvisations at every stage to adapt two techniques together, or two ways of addressing problems in a complex patient where multiple lesions are there. So this is the OCT picture. As you can see here, looks quite good, and this is the final result. Looks quite reasonable with all the treatment done into these LAD and left main. So another last patient, and you can see this is one of my very favorite patients, and this is a young man. You can see this quite bad LAD. Patient is quite stable otherwise. He's not unstable. He's in the ward. He's being planned for a surgery, but he had a very bad liver disease, and the anesthetist actually said that probably it's not a good case. He was, I think, from Russia, drank too much of vodka. So we had to then finally plan to do an intervention in this patient. So that was the good part, that we had time to make our plans. So we decided that we'll have to treat it like a bifurcation. There is no question. And the circumflex and the LAD both have to be treated. And as you can see here, the LAD is also badly diseased in the proximal part. And of course, there is a calcification here. So everything was bad here. And any complication during the procedure would lead to collapse of this patient, certainly. So we kept balloon and impella both standby, whatever was required. But we started with the wiring of and took some good pictures. It was not very clear where the ostium of the circ is, and the bifurcation was not extremely obvious how to enter into these two vessels, because both were very tight. And you can see that somehow we were able to put two wires, one in the LAD and one in the circumflex, and these are I think the BMW wires. And then followed by the first, we planned to do the LAD because it was beyond the this bifurcation and very calcified. So this will also give us some idea how the balloons will cross. So we did the dilatation in the proximal LAD, and then of course also into the proximal left main, and then dilated the from left main into the circumflex also. So we did the pre-dilatations because we are fully committed to do it as a two-stent technique, because there was no question of doing a provisional stenting here. So we did the dilatations, and knowing that it is a calcified, very bad plaque, and with the big balloons, starting with a 2.5, then going to a 3.5 millimeter balloons. And then we put a stent into the a proximal LAD. And as you will see here, this is the first stent. And this is being treated as a side branch. And the balloon is there in the circumflex. And the anatomy was very complex. So we, as you will see, we are putting a stent in the LAD with the balloon in the circumflex. And once the stent was implanted, we took out the wire from the LAD and did the dilatation from the left main into the circumflex. This is the first crush, and then we tried to put a wire into the LAD to do the kiss, and we were able to do a kiss. The first kiss was done, and after that we put a stent into the circumflex, from the left main into the circumflex. So this becomes the main vessel for us. And thereafter, once the dilatation was done, we thought we will do a second kiss, but we were not able to do the second kiss, I think, in this case. And finally, we did the pot and left the patient with this kind of result, and the patient did very well after that. So basically, this was kind of very complex, and of course, in these kind of situations, we could not do the second kiss, but since we did the dilatation quite well initially, it remained quite okay. So this is the left main with the bifurcation and disease in the proximality. So to conclude, I think we have to keep trying, and eventually we'll find the solution in most of these complex situations of left main intervention, especially the distal left main intervention. Thank you very much. I'll stop sharing now. Hello.
Hello. Yeah, thank you, Dr. Praveen, for showing. You said simple cases and you showed very complex stuff. Thanks for sharing your experience. There are 700 plus participants, and there are some questions too. We should do some justice. We are slightly getting behind the schedule. We will take questions in the end. Request Sushil to introduce Amir and take from there.
So can we get Amir? Oh, wonderful. So Amir is there. Dr. I'm assuming he is a colleague of ours at Columbia University. He's a unique individual in that he's trained in cardiology, in training as an advanced heart failure cardiologist, doing ECMO, managing patients, the sickest patients, the transplant patients. And he also did an interventional cardiology fellowship. The idea of bringing heart failure, interventional cardiology all into one world and trying to manage this new emerging field of interventional heart failure. He also has, with the COVID epidemic, has been really sort of focused, looking at some of these patients, looking at some of the presentations. We've had a lot of publications from our university. Amir has led some of them, looking at this. And I think we thought it would be useful for in 10, 15 minutes to go through some of the findings. I mean, I think there's a lot of cardiac manifestations of COVID that we were surprised by to start, and I think it's important. And I know the pandemic is I know in India it's still ongoing and emerging as it is here. That I think it'd be useful for the audience, because they will see all these patients, and in the end, we just hope that everyone stays protected, stays safe, and is cautious with everything. So, without anything further, I'd like Amir to take over and discuss some of the interesting findings. Thanks, Amir, for joining us.
Thank you. It's a privilege to participate. I'm going to share my screen. Is it clear?
Yes, we can.
Okay, great. Thank you again for this opportunity. It was great to see some cardiology, but we should not forget that what we've been through, especially in the past 3 months in the New York area and all around the world. We're going to talk about some of the cardiovascular manifestations of the disease, but more specifically about acute coronary syndrome and how we try to respond to this pandemic with acute STEMIs or NSTEMIs. I do not have any disclosure, and also I need to emphasize that this information is our experience only, and the knowledge about COVID is rapidly evolving. We should not and replace this with the clinical judgment or expert recommendations from the communities or hospital societies. In terms of the objectives, I want to talk about the prevalence of ACS during the COVID pandemic, ACS presentations, STEMI or STEMI mimics, which will somehow dictate the response to COVID in the cath lab, pathophysiology, some about pharmacology, and then future directions. It is well known that the STEMI or ACS cases started declining throughout the pandemic.
The data from Spain showed a 40% reduction in primary PCI. Structural heart disease, even more, 81% reduction. This is the data from Italy that was one of the hotspots, and they had challenges. On the left is from Lombardy that showed ACS cases reduced. Similar data from Milan. And this is the data from America that showed on the right, on the left is 9 high volume centers at 38% reduction in terms of the ACS presentation during the lockdown mid-March. And also this is a recent data of New England Journal of Medicine that showed a significant reduction in Northern California, almost 48% patient per week reduction in ACS presentations. We had similar data within NYP, which includes 9 hospitals in New York metropolitan. In terms of our response and what we considered to move forward to treat the patients and serve them well, one was which patients are under investigation and which patients are definitely positive. But more importantly, we knew all through this pandemic that one of the predominant cardiovascular manifestations of the disease was thromboembolic events, and that could present with ACS or STEMI mimic presentations. Also, we knew these patients suffered from systemic illness, and therefore they develop myocarditis, myopericarditis, and stress-induced cardiomyopathies, which again could mimic ACS. And the other question and dilemma which still persists is what's the overall prognosis of these patients, irresponsive of if you treat them with PCI or not. And also not only serve our patients, but protect our healthcare workers and first-line responders, and be cautious about our PPEs, especially at the beginning when we had limited resources. Also, if we can achieve some of the metrics in the cath lab, and then some of the ideas of older treatments like lytic therapies that started resurfacing in areas that with the limited resources, are they useful or not? Initially in Italy, the data came, the cath lab was proactive, started taking the patients to the cath lab, but they found that less than 40% of those patients had lesions that needed to be treated. At the same time, the price was more exposure of the healthcare responders and operators, and they became sick. So they started thinking back, and that gave everyone a pause. This is a patient, a lady, middle-aged, with some risk factors, presented with angina type and shortness of breath, dyspnea, had some high-risk features on EKG, as you can see. And then when they took her to the cath lab, the angiogram was normal, but she was COVID positive. This is a data from New York area, 6 hospitals. They found 18 patients in that period. They took the patients with COVID to the cath lab. But what was interesting is that even presentation of ACS in this population is different. Only 33% of those patients had classic chest pain or angina symptoms, and also the ST elevation, which we recognize even with our own experience happened during the course of the disease while they were extremely ill in the hospital. Regardless, 50% of those patients received angiography, and 6 out of 9 had an obstructive disease and were treated. No matter what, the outcome in hospital mortality extremely poor, more than 72%, and 4 patients with AMI passed away, unfortunately. So how we try to triage our patients when we started getting the surge in New York area and within our hospital systems, we try to emphasize on good history and physical, but remember, a lot of these patients are in distress, they're intubated, and no one is around, their families are not allowed to come, so that was very limited. EKG, but we all know that there are a lot of diseases, special with this realm, that can present with STEMI mimics on EKG, but what really helped us was the point of care echocardiography, which at our center, imaging center, really championed this technology, and that was extremely useful. This is the data. This is the document from responsible societies published early during the phase in the United States at how our cath labs should respond and how we should prepare. I think at the Columbia, Dr. Courtney and Dr. Kodali were the leaders in terms of managing the crisis. But we dedicated cath labs, COVID and non-COVID cath labs. But more importantly, which was our emphasis, was that these patients need to be treated appropriately, and we thought the appropriate treatment for these patients were primary PCI, keeping in mind that we need to protect our nurses, frontliners, and operators and doctors. So how to triage? There was a nasal swab, but we know it's not a perfect world. Only 60% positive predictive value with the swabs that we have, unfortunately. Therefore, it was a must for all of us to wear full PPEs when we're treating the patients coming to the cath lab. This was the pathway that we created and we published. Essentially, emphasis on bedside echocardiography to triage the patients is as accurate as possible. It was not perfect, but again, very, very helpful. And then we divided our response to essentially 3 time zones or tiers. At the beginning of crisis, which there were extremely limited resources, tier 2 contingency period, and now we are hopefully we're in tier 3, and we're going back to some sort of normalcy. Regardless, we thought that primary PCI was the best option. Why lytics are not our best friend? We know there is a paucity and good data that lytics should be applied within 60 minutes. A lot of these patients, for obvious reasons, presented really late. Also, the notion of protecting the cath lab and cath lab staff and operators and not exposing them was out of context, because these patients, regardless, may need to go back to the cath lab. And also, we've learned that a lot of these patients presented with pericardial effusion, and they may not have like ACS, and then we had catastrophes with lytics. The other entity that we started noticing these days is collateral damage. A lot of these patients started coming to the hospital late, but now that we are trying to reopen, we see more and more of these patients. For example, this gentleman with known CAD had some, fever and shortness of breath for about 5 to 6 days. He tried to avoid rightfully to come to the emergency room, but as you can see, when he presented with stroke, not even ACS presentation, COVID was positive. He had high troponin. He had features of heart failure, and as you can see, he had Q waves on his EKGs. And unfortunately, this was his echocardiogram, as you can see, with severe heart failure and LV dysfunction. The other surrogate for this late presentations were outside hospital cardiac arrest. This is the data from Italy. More than 50% been observed in terms of the cardiac arrest. We have the similar data within our NYP system that we submitted, and hopefully will be published so I can show you the data. This is another case, as I mentioned, as like a lady with some vague symptoms, not necessarily ACS symptoms. She had some diarrheal disease and some fever, came to the hospital. As you can see, the EKG was significant for inferior STEMI. She had elements of inferior involvement with low blood pressure and also bradycardia. We did, troponin was high, very, very significant metabolic disarray, as you can see, and end organ dysfunction. And then we did a bedside echo, as you can see, with highlights of RV infarction with inferior wall damage. Because we knew the patient is in shock, and this is our practice, we proceeded first with right heart catheterization to determine if the patient needs more support prior to any intervention. Cardiac index was very low. We started inotropes, and we clearly recognized that the high CVP and low PAPI, the patient is in trouble. The left system is pretty clear, very small circ, but as you can see, heavy thrombus burden in the RCA. Patient was in the shocks, and we thought that we need to intervene. In terms of the pathophysiology, yes, there is some data that showed, especially from prior pandemics like influenza, that it can destabilize the plaque. But what we saw and been reported as our experience was the type 2 MIs, especially with thromboembolic etiologies. We used a manual and then mechanical aspiration with penumbra, as you can see how much clot we tried to aspirate, and this was the suboptimal but final angiographic result. At this point, we used Cangalore converted to Brilinta, and as well as the Agristat on top of the aspirin of the pharmacology. This is a simulation based on her data that showed a very elevated CVP at the end of our intervention, again with low PAPI, still suboptimal cardiac index, and at this point decision was to proceed with right-sided Impella support. And she had a quick response, urine output picked up, and within the few days of hospital admission, we were able to successfully discontinue the Impella, and you can see the end organs recovered. There are many unanswered questions, and I hope we don't go through the second wave or other surges, but these are the things that we need to consider, and hopefully we'll be better in our responses. One is how reliably we can live up to the conventional metrics for STEMI, like door to balloon pump, door to balloon time, and etc. What is the pathophysiology? Because that dictates our management and medical therapy. If this is pure thromboembolic, should we start vitamin K inhibitors or DOACs with Plavix? Some of them really do not need stenting. And also the dilemma with some of these patients because of late presentation, like the gentleman that I showed you, the damage is done, and these patients now need advanced therapies, durable VAD or transplant. Really, which one is the best for these patients? And more importantly is, when do you think the patient is clear in terms of the virus and viral shedding so they can receive these advanced therapies that initially required to suppress their immune system? So with that, I will stop, and I thank you again for this opportunity.
Amir, for sharing your experience of managing COVID cases. In India, we are fortunate that we don't see such a heavy onslaught of very sick cases, though we have case numbers going up. Maybe because of Indians have better immunity or various other theories. Fortunately, we have a little younger lot. We have never come across a patient where LVAD or support systems, though they are not available, we never use them in our sick patients. We do get some patients, acute MI, STEMI mimics like that in our country, but we have not getting too much into the cardiogenic shock type of situations, maybe because of that happens with more of large immunity reactions and SARS-like syndrome, shock-like lungs. Fortunately, maybe but still we are on the rise of COVID cases. I think
I think that's important to emphasize, because especially participants from across the country, there are obviously some hotspots in India, as you said.
Yes.
And I think the experience from Italy, and Ajay's looked into this more as head of the cath lab, and maybe he can comment, that a lot of the infection rate among healthcare workers was high, and cardiology was one of the highest rates, because a lot of these patients presented with symptoms that were mimics of cardiac disease. So the lack of protection and lack of sort of using those same precautions, and I think we don't want the same mistakes repeated, and I think maybe I'll ask Ajay to make comments on his thoughts about what level of protection and what people should do up front, and I think doing this early on, taking extra precaution is always worthwhile. Ajay, do you want to make a few comments?
Yeah, so just two things. One is first, for all of those that are listening, we were petrified, I have to be honest, when we saw what the level of protection that our Chinese colleagues were wearing and what was happening in Italy. And we did not have full suits and full masks and those types of things. But what I can tell you is that when we had N95s and we went to masking of all patients in the hospital, the rates of nosocomial transmission and also the rates of physicians or other healthcare worker related infection appeared to be very similar to that of what it was in the New York community. So I think that if you wear the mask and you mask the patients, and especially if you have N95s, you don't, at least in our experience, we didn't need the full hazmat suits and all of that. And that was really, really reassuring to many physicians. I think that the other aspect is that you have to be judicious about the patients. And it's not that everybody with ST elevation needs to go to the cath lab. And Amir really nicely stated that we were doing these point of care ultrasounds, which really helped get the myocarditis not having to come into the cath lab. And then to Srinivas's point about the shock cases, you know, the problem with these things is you never know what the denominator is. And you may see on social media approvals for devices. The FDA approved the use of RP Impella. We use the device, you know, 2 times, I think, or once in all the time we were here. Amir showed that case, but the denominator is much, much bigger. And the same exact thing is true with the PCI and the left main PCI. There was a question that came in through the comments: when do you decide to use it? Really instructive to see all of Dr. Matthews' cases, super complicated rota calcification, and almost none of those cases had a support device in. So I think that when we hear about these types of things, always tools are good to have, and it's good to know when to use them. But the denominator often doesn't get appropriately conveyed. And I think that that's really, really important, especially for younger operators to understand. Because if you go to conferences, you only see the toughest cases, but what you don't realize is that the operators that are showing those cases, for most of them, it's not an everyday thing. They're showing their best case over the past 3 months, 6 months or so, and you're just getting all of them together at once.
Thank you, Ajay, for your comments. I think we're running out of time. We'll take a few important screen questions from a lot of the questions which are sent. I'm very happy that people from Kathmandu, Bangladesh, and various other regions also participated. But a few of the important questions I will take. Dr. V.T. Shah, Senior Interventional Cardiologist from Mumbai. We want to know from Ajay, do you have a meta-analysis on imaging versus non-imaging in left main in the recently conducted trial?
Yeah, there are some that have been out there. They're not great because they're not randomized, but I can tell you that that there is no meta-analysis or any analysis that I'm aware of that shows that imaging is worse. And there are plenty of observational analyses that have shown that imaging in complex lesion subsets is better. And the final point that I made during my talk is, remember, excel, if you will, with the best that PCI could offer. Best stents, imaging used in 3/4 of cases, et cetera, and we still didn't match surgery in those outcomes. So I would say to you, if you're going to stent somebody's left main, you would want to try to use absolutely everything you could to make sure the outcomes are optimized.
Dr. Ravi Shahi from Kathmandu wants to know, what would be treatment strategy for the patient with left main disease and diabetes with syntax score of 22? Low tertiary syntax score in diabetic patient. What would you do? He wants to know from you.
Anyway, Professor Guayumi, you want to answer? How do you take care of these patients?
Well, I think that for diabetes, there are no doubts that based upon also the data that you show in the longer term prognosis, I wanted to say that in this case, in any case, we are meeting with a heart team and much more in favor to go to the surgical revascularization.
Yeah, I think that it has to be individualized. The data, that's why you take somebody off the table and you discuss, because I think the data would favor surgery, but there are many patients, like Cecile said earlier, who won't want to have surgery done. And as long as the discussion is an open discussion and you talk about increased revascularization, increased late MIs, if they understand those things, they may still pick to do intervention, in which case, obviously, with that type of syntax score, it seems like a more straightforward intervention.
I think we started with this heart team discussion, and I just want to go back to that point. I think the patient needs to be a part of the heart team, and we need to get honest opinions on everything. One question to the group I'd like to ask is, somebody has a CTO, and how does that factor into the discussion, and how does that factor into the treatment planning? It goes back to the importance of complete revascularization, and so do you do the CTO first, and if you fail, then say they should go to CABG. How do you factor in CTOs and likelihood of success into the conversation?
Yeah, I would say it depends on the amount of myocardium subtended by the CTO, how easy or hard it is to do the CTO, age of the patient, and how relevant the CTO is. But I think in general, if you were to make a summary statement, CTO is generally going to favor surgery more, because most operators don't have the advanced technical capacities to be able to achieve 90+% success safely in most CTO lesions.
Yeah, thank you, Ajay. We'll take another question. Dr. Rizwana Siddiqui from Dhaka wants to know, is there any correlation between calcium score and calcification grade? Professor Julio, you want to answer this? Calcium score and calcification grade, she says.
Well, there is one famous publication done by the group of Akiko, and that was clearly identifying three major parameters that are dictating the calcium score. The one is the thickness, more than 500 microns. The second one is the length, more than 5 centimeters. And the second one is the arc of the circumference. The more you are combining these three different factors in the score, and the higher is the score, and the easy is the prediction of the suboptimal stent result. So I think that is an important point to start with. The second important point is to get the evidence of the fracture, because if you, number one, many patients they have a very high calcium score, they might have some difficulty in dealing with the OCT or IVUS catheter down without doing any sort of pre-deal or lesion preparation. And number two, when you assess the calcium score and you are making more aggressive lesion preparation, then you needed to show the fracture before going to the stent implantation.
You know, the tough thing that, and maybe the question was asking, is CT-based calcium scoring, and is there a correlation in the lab? We don't know for sure. It's not been strictly discussed, because you can have coronary calcium that's not going to impact the lumen. But what I would say is, if you have a patient with a very high CT calcium score, 100% image that patient to see what's going on, because those are types of cases where you got to be even more cautious. Similarly, Sushil knows this very well in the valvular disease practice, but patients with severe AS who have calcific AS, you know, even if you don't see angiographic calcification, that those patients may frequently have calcification in the vessels if you were to image it.
Can I also, maybe on a slightly different topic, ask a mirror question? Part of the during this COVID thing, cardiac things, there's just a lot of different things that were tried, from hydroxychloroquine to different drugs to TOSI. One of the things that is relevant to the cardiac field is the role of anticoagulation. At this point, what is your strategy? What is the evidence? And do you think patients should routinely get heparinized if they come in with ACS and are COVID positive? Not ACS, I'm sorry, not ACS, but COVID positive.
With COVID, actually, that was one of our early experiences. Even the lines, we were like A lines. So both arterial and venous, we had a lot of thromboembolics. Sushil rounded in COVID ICUs as well. But at the moment, there's a lot of data that are conflicting, and the same as our experience. So we have a randomized trial that's going within Columbia system to see that patients that need full anticoagulation just for COVID, and versus the medium dose, not necessarily prophylaxis. But regardless, if there are any signs of hypercoagulated state, not genetically, but because of this viral invasion, at least practice in CCU was I put them on moderate doses, as long as there are no risk of bleeding.
Yeah, I think there will be a lot more questions for COVID, I think, but we are running slightly out of time. One relevant question, which I thought pre-PCI imaging and all that is covered. One of the Dr. Anil Kumar from Panchkula wants to know role of imaging in pre-PCI. I think he has covered it already. Dr. Satnam Singh from Bournemouth wants to know what is the indication and data supporting the use of IABP in unstable left main disease.
Yeah, I think unstable is different. So for stable, remember the Excel and Noble used support. Excel specifically used support, approximately 5% of the time, and the EFs were normal. For unstable, it's a tougher situation. And as we know, balloon pumps, the data is not great, particularly for shock patients. In this intermediate category, it's hard to know. I think it's better than nothing. And the more supportive devices are typically going to be better than the less supportive devices, but there's more bleeding complications associated with it. So I think you just have to be very, very judicious, and a lot of it is dependent upon how the patient's either deteriorating or stabilizing, and making decisions in that light.
Thank you, Ajay. Actually, one point I wanted to make it clear to all the people who have logged in is ACS acute MI with left main is a slightly different scenario. From NIC data, what we collected in India, we do see a lot of patients. Actually, 2.5% of PCIs had left main with unstable syndromes. So that sort of thing, getting surgical organized consult and treatment organized we lose a lot of time. And surgeons also are not comfortable in operating these patients. So saving life in that scenario becomes more important. And if you have other diseases, it can be tackled later. But actually treating in acute MI phase and when the patient is unstable, revascularization goes a long way. I think all the trials and other parts come later. But to save acutely ill sick patients with very tight left main sometimes becomes a priority. And we interventional cardiologists, all of us have experience of saving lives of such patients. Hope you all would agree with this. And
and I think that needs to be re-emphasized to the audience is that if you have an ACS left main, time is of the essence there, and it's almost always going to favor a PCI-based approach if that strategy is feasible.
Yeah. Thank you. I think we have already extended your time, Ajay, but last point, which I would like to ask before we close is, which are the subsets of patients which you send for surgery in today's era? Seeing Praveens and Sam Matthews cases and cases shown by Julio, we will be worried which patients go for surgery. In Colombia, which are the subsets of patients which you send for surgery where there is a PCI is no?
I think that certainly so as I said, we take everybody off the table unless they're having an acute coronary syndrome and we discuss it. I think we have to be dispassionate about it and not get too attached to the decision as long as we think it's right for what the patient selects, as Sushil said, bringing the patient into the picture. But patients that I think we would really say, look, you really should have surgery are probably those, with, you'd have to put in 9 stents in order to revascularize the patient adequately. The EF is just so low. Maybe concomitant valvular disease because they might be able to treat the valve at the same time. But as similar to the cases Dr. Matthew and Chandra showed, frequently, the vast majority of the left mains that I do are referred from the surgeons. So they've seen a surgeon and the patient either doesn't want surgery or the surgeon feels the patient is too high risk. And so therefore we end up doing PCI on those patients.
Professor Julio, you want to take that before we conclude?
Well, I think that one of the points Jay was addressing was the last data moving forward toward to be more in favor of the surgical decision in the left main. And I'm going back to the time of the syntax when we did Jay. And one of the most intriguing slides was the ones that was dedicated to each center. So you had small or large balls depending upon the numbers of patient enrolls. And on the 2 axes, you have the performance of the surgeons and the performance of the interventional cardiology. So I think that we should stay in contact with the real life, that each center should evaluate his own capability on both sides. It's not only a matter of indication, but it's also a matter of how to approach the patients in terms of numbers of arterial conduits. So I think this is quite important.
Yeah, the individual operator differences at the surgical, the operator on the PCI, and also even what the hospital can do level really will change how you treat patients as well.
Thank you. I think we've learned a lot through this webinar. Thank you, Ajay, Sushil, and Amir, and Professor Julio, and Dr. Matthews, and Praveen Chandra for sharing their experiences. What we've learned in the last 2 hours is basically we have now strong data to show that left main interventions will work, especially for ostium and the shaft. It is almost becoming a class 1A indication according to European guidelines. Bifurcation, we still need to take help of imaging and perform a good procedure. If immediate results are good, you will have good long-term results. As shown by bed preparation and calcific lesion approach is important, and imaging plays a lot of role in it, and OCT, as depicted by good cases from Julio, helps a lot for doing the procedure right to these patients. And we also learned in the end what is the experiences of Colombia regarding management of COVID patients. Before we close, last words from Sushil.
No, I think you summarized it well, Srinath. I want to thank everyone for their help in the seminar. I think it's great to be able to do this. When we can't get together directly, I think a lot of this learning can be transmitted remotely, and it's great discussion. And I want to thank everyone for joining, and I hope the participants enjoyed and more importantly, learned from this session.
Thank you again. We should be also thanking Abbott Vascular, who was coordinating and helping us to organize this and sponsoring this program of this event. And Jaspreet, Subodh, Anil, a lot of other people who are involved. We're extremely thankful. And we also want to utilize this opportunity to inform everybody that TCT India, which we do in partnership with CRS, CRF will be also a virtual event, July 30, 31st and 1st August are the dates. And many more interesting things we are planning to do in it. And I request all of you to keep a watch. First time of your lifetime experiences, the COVID is teaching us. We will also hear a lot of new things and a lot of new experiences in the coming TCT meeting. And we're very fortunate to have these two great friends and colleagues, Dr. Ajay and Sushil, who make everything possible for us. Thank you, Ajay and Sushil, for getting again continuing patronage and help in making TCT in our country. And with this, any last words from Ajay?
No, thanks so much. This is always great and fun, and it's encouraging to see so many people involved, and social media already commenting about it. So we feel that hopefully it'll help you in your practice and hopefully your patients too.
Thank you, Ajay. Then bye-bye, everybody, and hope we all stay safe and take care, because you have still very active COVID cases coming in there in New York. Hopefully, we are not in that stage yet. Thank you.
Yeah.
Okay.
Bye-bye.
Bye.
Bye.